available operation, at least in experienced hands, with an operative mortality of less than 1%, and more than 90% of patients, if they leave the operating room with a competent valve that is closing like this, they have a 90% chance of getting out to 15 to 20 years with the valve still working. The freedom from endocarditis and thromboembolism are better than with composite grafts, and reoperation rates in the BEST series are very similar. But I will say that surgeons with less experience with valve sparing routes, the reoperation rates are higher for the valve sparing. But if you have patients that are young patients with connective tissue disorders who are prone to dilatation of the annulus, I strongly encourage you to regard the reimplantation procedure as the procedure of choice. But it will be interesting to see if these newer versions of the remodeling operation, like the Schaefer's and the Lansac ring, will combine the best of the remodeling procedure with annular stabilization and produce results that are comparable to the reimplantation. So again, I thank you very much for the invitation to share some of this information with you. These are, I think, challenging operations, usually best done by people who are very comfortable and safe aortic surgeons. But perhaps the best advice I can give you, if you want to begin to do this surgery, is find another surgeon who does these operations well already, and do this as a team. Because I think that even now, with as many as I've done, this is an operation that I really feel is much safer in the hands of two surgeons. 4 eyes looking at the operation, the easiest part of the suture line done by the surgeon who can see it the best. And it's a good quality control measure to make sure that all of our patients have the best possible outcomes. Thank you very much.
Thank you, Dr. Cameron, for your superb lecture this afternoon. As for the invited lecture, we usually do not have a question and answer. However, I would like to give a couple of audience having the privilege of question for Dr. Cameron. Is there any question from the audience? Dr. Moon, please.
Dr. Cameron, as usual, thank you so much for such a comprehensive study of the aortic replacement by valve sparing. In regards to annular dilatation you were concerned about, and I noticed that for you, when you modified it, you only put 3 outer sutures to bring it out, and sometimes people put different rings on it. When I learned from Dr. David, we used to put interrupted sutures around the outer layer completely, almost like as if we got some sort of a ring on it. Mm-hmm. And then did a second layer inside, which I called the hemostatic layer. Do you think if you actually put more than 3 sutures interrupted, but if you put a complete ring of interrupted sutures to make that not just hemostatic, more so to keep that annulus from dilating, do you think that might actually inhibit the annular dilatation? But thank you again for your...
Well, thank you for your kind words. And this is a very good question, and a question that I hear a lot. First of all, the annular dilatation does not occur with the reimplantation, whether you put 3 sutures in or 18, because the annulus fits entirely inside the graft, and the annulus is supported by the 3 at the bottom. If those sutures stay there, then there's nowhere for the annulus to go. It's going to be supported completely by the graft. So the number of sutures that you put at the bottom does not have an effect on annular dilatation. The annulus will not dilate. Where I will agree, though, is that if you only use 3, then the bottom suture line offers very little for hemostasis, and that it becomes even more important for the upper layer, the hemostatic suture line, to be perfect. Now, if there is any leak at all, even needle holes from the internal hemostatic suture line, you will see some blood come out from the bottom of the graft. But if you put just a plicating stitch at the base of the graft below the commissures, it tightens up that bottom collar around the base, and that will stop the needle hole bleeding. If there's significant bleeding, a lot, then there's a problem with the internal suture line, and you need to open and fix that. But this is a technique that we've used in 300 patients with, I think, very good results and very low rates of reoperation for bleeding. If there is a problem with just 3 sutures, I would say that it might be with the Loeys-Dietz patients, where we have seen some patients come back with pseudoaneurysms from the suture that is below the non-coronary. And it's possible that with only 3 sutures, there's more tension on that suture line below the non-coronary sinus. Every time the heart squeezes, it's trying to push the graft off. And that stitch probably has a little bit more tension to it. But I honestly think that it's actually not the number of stitches, it's the tissue in the aortomitral apron in Loeys-Dietz, I think, is very, very weak. And I think just having some extra stitches there sometimes will help. The reason I'm not sure that it's the number of stitches, though, is that we have operated or reoperated on several Loeys-Dietz syndrome patients who had these pseudoaneurysms in the non-coronary, but they had 18 stitches. So I'm not sure it's the number of stitches. I think it's the tissue in Loeys-Dietz in that particular area, the aortomitral apron. But don't worry about annular dilatation. It doesn't matter how many sutures are underneath the valve there. But more sutures it might help hemostasis if the top suture line isn't perfect.
Thank you. Dr. Kwak?
Thank you very much for your lectures. I'm Dr. Kwak from Seoul National University Children's Hospital. So, would you share your experience for the patients with Ross operation with the same pathology, with the aortic regurgitation and ventilation? Is it still useful for them, this technique?
So you're asking about patients who have dilated root and aortic regurgitation
After Ross operation.
and the Ross. So is your question, how do you decide between a Ross and a valve sparing, or what do you do with a patient who's had a Ross and now comes back with a dilated autograft?
And later one.
Yes. So this operation is very good for many patients who have had a Ross and come back now with a dilated root and recurrent regurgitation. It all depends on the quality of the leaflets. Sometimes it's only because the autograft is dilated, the sinotubular junction is dilated, and the annulus is dilated, but the leaflets are fine. And if that's the case, you can do a valve sparing in a patient who's had a Ross, and the results are very good. But many times the leaflets have become so thinned and stretched out or torn that it's not going to be a good operation. So in our experience, about half of the Ross procedure patients with a big root and AR, we saved the valve again by doing a valve sparing root. But the other half, the leaflets are too damaged and you need to replace the valve and the root.
Last question, Dr. Kim.
I'm Sung Kim, working for Samsung Medical Center, Seoul, Korea. You didn't mention about the fenestration on the leaflet. Some surgeons go to the dental operation in the case of fenestration, but some doesn't. They put some vortex stitches along the free edge. What is your opinion about that?
Well, thank you for asking that question. I see fenestrations as a marker of damage to the leaflets, and as the root dilates, the stress on the leaflets moves up to the commissures, and if you look at where the stress is on a leaflet during closure of the valve, it's highest up there in the commissures where the leaflet is hanging, and it's less right in the middle where the leaflets are supporting each other. So I think it's an index of damage to the leaflet, and whether or not you go to a Bentall or try to repair it depends on the patient. If you have, say, a 14-year-old girl from Saudi Arabia who's hoping to have children later on, I think you are going to try to work harder to save the valve and to try to repair it. But a 70-year-old man who has a lot of fenestrations, I don't think it's worth trying to save that valve, because that's a patient who will do very well with the bioprosthesis. So the fenestrations, what to do about them depends a lot on the patient, and it also depends whether it is a valve that you can actually repair. Normally in this talk I have a picture of a Marfan syndrome patient with severe fenestrations. And the point of the picture is that the leaflets are so thin at the free edge at that fenestration, you cannot sew to them. There's no way. If the valve has a lot, still most of the body of it has some thickness and strength to it, yes, you can run a Gore-Tex stitch and close the fenestration. But it depends how severe the fenestrations are and what the rest of the valve looks like. It's like everything else in surgery. It's all about judgment, and maybe not so much knowing when to do an operation, but when you should not do an operation. That's how you get the best results, is figuring out who shouldn't have the operation.
Thank you, Dr. Cameron.
Thank you.
We prepare a letter of appreciation and small honorarium for you, but it's better to read here. Okay.
Thank you.
Letter of appreciation, Duke Cameron. We deeply appreciate your inspiring lecture entitled Valve Sparing Aortic Root Replacement in Coronary Era, presented at the annual Autumn Congress of Korean Society for Thoracic and Cardiovascular Surgery, October 25. Kim Kim.
Thank you very much.